All right, so today we'll be talking about actually things, diagnosis and clinical management of neurotrophic lateral sclerosis, as well as after this one, we'll be talking about hyperexcitability syndromes. So amyotrophic lateral sclerosis is actually one of the most common motor neuron diseases. Okay. Initially, it was thought to be just one of the motor neuron disease, just involving extremities. However, it's found to be involving a lot more than that, including the brainstem, and also your spinal cord. In fact, ALS is actually a spectrum of motor neuron diseases where you have upper and lower motor neuron, whether sporadic, inherited, genetic involvement, all of that basically forming a general or major spectrum of disorders. It's not only just involving your muscles, it can also involve your brain. Some of the phenotypes, such as, for example, ALS, involving the frontotemporal lobes, hippocampus. So it's not just the motor neuron disease as initially thought. Let's look at the pathology of ALS. So the name as it generates, amyotrophy, which is muscle loss, and the lateral sclerosis, that means just involving the lateral corticospinal tract. As we can see over here in this picture, there's some eosinophilic granules, which were actually identified as Benina bodies, which are just like a ubiquitin positive inclusion body, merely an accumulation of a DNA binding protein identified as TDP43 that has been involved in actually RNA toxicity, leading to a cytoskeletal degeneration or infection, which by the end leads to degeneration of these motor neuron cells. As we can over here look in the pathophysiology, not only the TDP was involved, actually other genes or proteins such as SOD1 was involved, eventually leading to this RNA toxicity and the cytoskeletal impairment and dysfunction. Mostly these proteins are ubiquitin, which of course should be destroyed by proteasomes, but they end up accumulating for some reason, especially if the cells undergo a stress. Hence, you'll see that most of the treatments are actually looking at addressing stress and oxidative and free radical scavengers. In terms of genetics, SOD1 was actually the first gene involved. When they found it, they said, okay, maybe we got it. Now let's try to make this model of this disease and try to address the disease and treat it. However, it did not really involve the other proteins such as the TDP43. Hence, that was found that there's multiple mechanisms that actually lead to this disease. In addition, other genes like, for example, the target DP55 plus, most recently the C9 or 72 gene, I don't know. I actually don't know how it is involved, but it was found to be involved in the frontotemporal dementia in cases of ALS. So in general, the clinical presentation of ALS is really well known. Upper motor neuron involvement and lower motor neuron involvement. For the lower motor neuron signs, including weakness, fasciculations, and atrophy. Upper motor neurons, mostly involving the spasticity, hyperreflexia, and pathological reflexes. When looking at the clinical picture of ALS, often the main clue is the involvement of no sensory affection, as well as it's a painless disease. So you'll find patients over the course of a year starting to develop weakness, fatigue. They go to different physicians. They go to different, if it's got pulmonologists, they don't really know what's going on with them. And it kind of leads to frustration because ALS is not really a very simple disease to identify and diagnose, because there's no a single diagnostic or gold standard to say, oh yeah, this is ALS. So by the time they've been by many physicians, a year or two has already passed. But classically, it will show progressive limb weakness, as well as the spinal form of it, which is a rostrocaudal spread initially in one limb, and then it goes to the other limb, and then it starts involving the other as well. Different criteria were actually just mainly, there are mainly two criteria: the Escorial criteria, which was also revised, and then there's another diagnostic criteria that we'll talk about in a bit. It categorizes ALS in regions. So when you're looking at the signs and symptoms, mostly here, basically the signs of upper motor of ALS, they divided it either bulbar, cervical, thoracic, or lumbosacral. The cervical involving Hoffman, Comner, finger flexors involvement. The bulbar basically shows exaggerated gag reflex, snout, or pseudobulbar affect and portions. Actually, I was not able to identify if you've seen the portions before. Like I don't know how would it be like. Yeah, over there, portions. I just don't know how to be over here. Portions. Yeah. I never seen it. I don't know if you have actually seen it before.
Well, yeah, in advanced ALS, like, there are patients who can't even move their mouth, like they can arthritis, and so with their respiratory weakness, you can see as they're gasping for air, it almost looks like they're.
Oh, okay, yeah. Because I was like wondering if it's actually they were young, but anyway. So with the thoracic involvement, you'll find that you start losing your superficial abdominal reflexes, lumbosacral, you lose your plantar reflex. But one of the main things that you must look for when examining the patient is basically bladder or bowel dysfunction, as well as the central loss, because if they are involved, mostly it's actually a different diagnosis than ALS, which does not really involve these areas. So over here, it's looking at this table looks at the different phenotypes of ALS, which is surprisingly a lot. You have the classical ALS, basically involving the bulbar, upper and lower extremities, respiratory onset, which just starts initially in the bulbar and involves the diaphragm, primary lateral sclerosis, which mainly is a upper motor neuron kind of, and then other areas such as Morvan Syndrome, where you just have neck weakness, ALS with frontotemporal dementia, and of course others. So when I looked at the ALS epidemiology, basically it's a rare disease involving about 1.4 to 100% incidence per year, and estimated 5 per 100,000 people, which this discrepancy between the incidence and the prevalence is actually just shows that how these patients just don't live for long, just to form like a 5 per 100,000 prevalence. But the cumulative lifetime risk is actually 1 in 400, which is kind of quite high. I mean, although it's just a rare disease. The other really interesting fact about ALS is the amount of frontotemporal dementia involved in these patients. 50% will show executive dysfunction, which again challenges the thought that ALS was actually a simple pure motor neuron disease. So when we're looking at ALS and we're trying to diagnose it, it definitely involves a lot of methods. Clinically, neuroimaging, electrodiagnostic, history, labs. All of this is basically a combined effort to mostly rule out other diseases that may mimic ALS. Um, Especially when you're looking at the motor responses from the neurodiagnostics. It's mainly the neurosensory, the normal sensory response, which kind of, if you see them, you kind of rule out the ALS. Um, so EMGs, they'll show a polyphasic motor neuron unit with a reduced recruitment pattern. This is because you have um, denervation of the muscles that were actually involved in ALS, and then reinnervating by the neighboring motor neurons during the course of how the disease progress. But mainly when you're trying to do the EMG, you have to involve different regions, because when you look at the criteria, you have to have at least 3 regions involving the bulbar, cervical, thoracic, and lumbosacral. Interestingly, I didn't really think about this, but the paraspinal region was the lower, especially the lower thoracic area, the lower lumbar area, was found to have high specificity when you find these electromyographic patterns. One of the other things as well, which is kind of a little bit more specific to ALS, is when you look at the compound motor action potentials recorded from the thenar and the dorsal interosseous muscles, are actually reduced in a way greater extent than the hypothenar muscles, which is something more specific to ALS. This
So,
ALS, the CMAPs with the thenar and the first dorsal interosseous, they're less.
no, I don't see that. Because by the time we're doing their,
It's all very
usually
yeah,
progressive and-
late, yeah.
Yeah, but one point to make is that we do a lot of EMGs for a very simple condition called carpal tunnel. And one very common mistake that's done by inexperienced EMGers is to call everything carpal tunnel that one. So he kind of touched on sensory and motor. So if you have a really normal median sensory response and a really abnormal median motor response, what does that?
That makes them think more less.
Well, I wouldn't think ALS necessarily.
Oh, no.
You know what I mean?
Yeah,
If
in
they
the
didn't have the
clinical picture,
clinical
yeah.
pictures, but yeah, it would raise my antennas to say, should I be looking at other muscles to see if they're also, because sometimes we limit the test. If it's simple carpal tunnel and that's their only symptoms, we do those 2 nerves and we're done. But that should be a sign that I should look elsewhere and ask more questions. A lot of times patients don't realize. They feel tired all over, but we don't, they never bother to tell anybody. So you might see, or they've had a weight loss that they never seen. So, I think that's important. But no, I haven't noticed that thenar is more than hypothenar. That might be something they found with observation.
I mean, just thought that was really interesting.
Yeah.
So the differential diagnosis of ALS is actually a large differential. Whether the cause is sporadic, which mainly involves ALS and spinal lateral sclerosis, metabolic, hyperthyroidism, hypothyroidism, vitamins, B12, vitamin E, structural, such as trichomyelin, Arnold-Chiari. I mean, these are all conditions that will have some features that will involve the upper motor or lower motor neuron, especially B12 deficiency can cause both. Infections, HIV, multiple sclerosis. Also, one of the things that was really interesting was the stiff person syndrome as one of the differential diagnoses for ALS. Inclusion body that was really very, I don't know why they.
Why would you think that they would put that on?
I mean, mostly because of the spasticity.
Spasticity,
Yeah.
exactly, the upper
Yeah.
motor neuron.
Yeah, I mean,
Risk reflex.
they all have a feature or two from
So
ALS.
there is an ALS variant that is probably more not consistent, but more in the differential of person than ALS. What is that? The ALS variant.
PLS, right?
Yes,
Yeah.
PLS, because PLS is basically only the upper motor neuron features of ALS. You don't get the atrophy, you don't get so wasting like that, but you only get like the spasticity, the bulbar symptoms. So sure, in theory, it could be similar at the earlier presentation with stickers.
All right. So again, when we're looking at the diagnostic evaluation, whether it's you're doing labs, looking at just rule out the other causes, whether you're looking for just the general EMP or B12 levels, and even go further, you're looking for CSF, heavy metals. It's not really that common though, but you're just trying to actually rule out other causes. Sometimes you can also go into mimics, such as, for example, if you're looking for spinal bulbar atrophy, or, for example, you can do SMN genes, but this is not really the common things. But mostly EMG is one of the most common in nerve conduction tests. Imaging, just dual instruction cause, but you won't really see much in ALS. So again, this is the criteria that was used to identify ALS. So there's mainly the ALS Coriol criteria in its revised version, as well as the WAGI. The WAGI is sorry. Oh yeah, the WAGI is mostly looking at the electrophysiological evidence behind it, while this Coriol is mostly looking at just the clinical part, where they say the clinical probability, if you have the upper motor plus lower motor neuron and the bulbar in two spinal regions, or an upper motor and a lower motor neuron in at least 3 spinal regions. That's why when you are examining the patient, you have to look at 3 regions, like I said, cervical, lumbar, and the thoracic. However, the clinical suspicion goes even less and less if you start to have patchy areas, such as, for example, if you have an upper motor and lower motor in one region and another in like 2 other separate regions. So the treatment of ALS is, of course, everyone knows that this is not a treatable disease. However, when we're looking at the treatment, we're basically trying to improve the quality of life of these patients. The first medication that we used was riluzole. Really not really much of a survival benefit, 2 to 3 months. But given the very fast progression of the disease, that may be something for these patients. Mainly addresses the NMDA receptor, the glutamate receptors, and the kinase as well, mostly from its toxicity that can cause when you have these cells undergo the stress it goes through. With the side effects, mostly GI, the upset, and you just need to monitor the liver enzymes during treatment with riluzole. Another medication, which is Darabone, it's also a free radical scavenger, was recently under investigation. It's not yet really in the United States, although it was actually approved in 2017. That's not in Europe, actually. They did the trials in Japan where they had different ALS functional rating scores from 1 to 4. And this medication really didn't really show much benefit. However, the time they did the data was actually 6 months, so it wasn't really that much. But again, if you're not in the United States, maybe in Europe or something, and you administer this medication, just given in batches of IV infusions, and the common side effects would just involve dermatitis and constipation with GI symptoms.
It's also like, I think, close to $100,000 a year.
Yeah, which is very, very expensive.
No non-benefit.
Yeah, just useless. It's not changing anything in the survivability, but I mean, they're trying whatever they can. But the other factors when you're looking at the treatment is, of course, the lifestyle, other than the medication itself. So the most common cause of these patients' death or demise is basically their respiratory status. They will stop breathing because, of course, they will have a paradoxical inward movement of the diaphragm, especially when they're sleeping at night. So they thought of, okay, let's start these patients on non-invasive ventilation. Usually when they do the FEV of less than 50%, they'll start them on non-invasive ventilation to help them breathe better, given that they have weakness in the diaphragm. Later on, of course, the weakness will get worse and will not be sufficient. So these patients will actually elect to have a tracheostomy done instead of being on mechanical ventilation. But of course, not everyone. That's why when you're treating ALS, you want to address the goals of care really early on. In regards of, you don't want the patient to decompensate and you have to have an emergent tracheostomy. Given that the idea of non-invasive ventilation was helpful, some people thought, let's do maybe a diaphragm pacing, which, which actually, given they did 2 studies. One was actually a sham study, but they're basically called the diaphragm pacing in patient respiratory insufficiency due to ALS and the early stage amyotrophic lateral sclerosis chronic stimulation was actually showing a worse survivability, so it was just useless. And I think diaphragm pacing is not really that common.
So we did it in fellowship, and the few things we were still studying it, and actually wrote like a retrospective review. But what we know is that patients felt more comfortable with the diaphragm pacer, and whether they did poorly or better, they felt more comfortable breathing because of there's like the stimulation to get it's basically stimulating the diaphragm to independently contract. But there was a high incidence of pneumothorax as a consequence of the procedure. And I don't think we found any significant difference in survival.
Yeah.
And it often required 1 or 2 hospital days stay, which then led to complications with infection.
Didn't really want to do that.
And I think it ended up being approved, FDA approved for like humanitarian reasons. So it wasn't approved under this robust evidence study.
Yeah, it's not changing its survivability. So yeah. The other thing is, of course, you want to look at their nutritional status, because these people were not eventually they'll start suffering from not able to swallow, dysphagia. So you want to address their nutritional support early on, mostly giving them high caloric and protein diet, maybe use milkshakes, whatever makes it easier for them. But of course, one of the things you want to address is if they want to have a PEC tube placed, because eventually they'll stop feeding. Other symptoms, of course, that you want to go through. For example, sialorrhea. Maybe initially they'll have, they're able to tolerate non-invasive ventilation, but then something like that comes up and they're not even able to tolerate it. So it's basically symptomatic treatment over here, whether you're giving them anticholinergic to decrease their secretions or antidepressants, baclofen for their spasms, laxative for their constipations. It's mostly just symptomatic or quality of life addressing in that population. So we have a case, someone wants to read it.
A 54-year-old woman noticed progressive dysarthria, and 3 to 4 months later, she began to cough when eating, and especially when drinking. A neurologic evaluation 1 year after symptom onset, she endorsed laughing and crying spells. On examination, she had a mixed spastic and flaccid dysarthria, decreased facial reflexes, retained limb strength and bulk without fasciculations, and brisk limb reflexes. Electrodiagnostic testing did not reveal denervation of the limbs. Imaging and lab assessments were normal. The patient was diagnosed with progressive bulbar palsy phenotype of ALS. Because of progressive dysarthria, the patient used pen and paper and electronic tablet to assist with communication. The patient was able to maintain her weight and with oral intake, but the progressive dysphagia prompted a feeding tube discussion. Despite difficulty in performing pulmonary function testing because of an impairment in forming a tight seal around the tube, her respiratory mechanics were initially normal. They eventually declined, and non-invasive ventilation was prescribed. The patient ultimately elected to receive a feeding tube because of progressive dysphagia. About 3 years after the onset of symptoms, progressive limb weakness developed. Although she was benefiting from non-invasive ventilation, Cialorrhea became problematic and limited her tolerance of non-invasive ventilation. Oral medications were not helpful, and Botox injections were pursued. An eye gaze system was recommended to aid in communication. The patient expressed a wish to not pursue tracheostomy should one become necessary, and early hospice was discussed.
Yeah, so I mean, this case just showed how very fast the progression came in, and how to address basically the symptoms. And despite that, this patient actually had no limb involvement initially, it got worse later, and that was involved. And basically, the use of methods such as the eye gaze, like the one that was used with Stephen Hawkins for a long time. These are all methods basically to try to improve their quality of life, basically. And of course, discussing these things early on makes it much more easier. Other, not really ALS, but other parts of the spectrum that we can discuss this in this lecture is basically primary lateral sclerosis, which is mostly an upper motor neuron rather than upper motor neuron and lower motor neuron disease, which typically involves just for all the four extremities symmetrically, and mostly you'll have spasticity as well as some bulbar onset later on with dysarthria and dysphagia. Again, you'll have the same upper motor neuron, mostly pure upper motor neuron, spasticity, hyperreflexia, and pathological reflexes, some degeneration seen on your EMG. This disease have a better survivability, like a 10-year survival, where the age of onset is a little bit later in your life, 59 years old. The other disease is progressive muscular atrophy, which is a little bit controversial because it was identified as a pure lower motor disease, which is not quite true. These patients will initially have lower motor neuron disease, and it will involve the lower extremities, but this time asymmetrically with weakness, fasciculation, hyperreflexia, just the lower motor neuron symptoms. But then later on, they might start developing upper motor neuron. So it's not really a pure lower motor neuron disease, but they consider it as a phenotype of ALS. Other ALS mimics, so spinal bulbar muscular atrophy, also known as the Kennedy disease, is actually an X-linked recessive disease, mostly involving a gene called CAG, which affects the androgen receptor genes. Hence, these patients, since it's actually affecting the androgen receptor, you'll find them developing gynecomastia, reduced fertility, other endocrine diseases such as diabetes, mellitus. Oral fasciculations is a very common, as well as the tongue fasciculations are common part of this disease. However, they will have a sensory neuropathy, hence the importance of making sure that the patient does have or does not have the sensory neuropathy, which quite changes the diagnosis. With spinal bulbar muscular atrophy, it's a little bit not as bad as ALS in terms of the respiratory, the survivability, although they will still have respiratory infections, and that will be the cause of the death instead of the respiratory compromise in ALS. The other one is the spinal muscular atrophy, which this time is an autosomal recessive degeneration of the anterior horn cells, involving the gene called SMN, which was found in the chromosome 5. Specifically, there's different, now like I think they have like 5 phenotypes of SMN. With SMN1, mostly in the centromere, and SMN2 is actually in the telomere part of the chromosome. SMN2 was found to have a specific variant, which is the exon 7, which does lead to which is involved in when it's removed, it naturally should lead to the normal production of the SMN1 protein. However, with the spinal muscular atrophy, this expression does not really happen, and they end up with the incomplete muscle protein. So nowadays, they're looking at newly approved medication called nusinersen, which actually gets that exon 7 to be involved and hence produce this protein, the SMN protein, which leads to a better function actually. The last one over here is basically the Hirayama disease, which is a male predominant juvenile onset disease involving mostly the upper extremity, because it's mostly the spinal cord disease involving the thinning of the anterior roots between C5 to basically T1, which is worse at C7 to C8. Over here, you look at the MRI, it's basically showing some thinning over here of the spinal cord. You can see how it's actually, I don't know, it's not compressed as in myelopathies or other diseases. It's just the thickness itself is much more increased in this disease specifically.
You're pointing to cord atrophy.
Yeah, the cord atrophy itself. Yeah. So, in summary, ALS is actually a multi-system disease, mostly neurodegenerative, involving the brain, the brainstem, typically most of the nervous system, involving the motor neuron disease. With cognition, basically identifying the early symptoms of ALS would help things to identify these patients for lead to a better quality of life in these patients. With also making sure that you don't want to misdiagnose these patients and start them on medication where they have something else going on that can actually save them, especially if you tell them someone you have ALS and you're going to die, it's not really something you want to do. Yeah. Anyway, so this is basically for ALS.
Can I make a couple comments? What's your next step?
Yeah, it's peripheral nerve hyperexcitability.
Okay, so few comments about ALS, especially so it looks like we have a new batch of students. So ALS doesn't have a cure, is not too hard to pick up if you know what you're looking for and spend the time to look for it. And it's quite interesting, especially because there are so many mimickers or things that you might mistake it for. And I'll give you some examples. Is anyone going into ortho? No? Okay. Well, I have seen patients come from ortho after multiple neck surgeries because they were having weakness in their arms. And imagine most of the cases of sporadic ALS are happening in their 50s and 60s, same age as spondylosis and spinal stenosis, where it begins. So that has happened. I've also had patients come from rheumatology on very high doses of steroids for many years because we thought it was a mild. So you want to go out there and kind of be able to pick up unusual features. So if it's not a typical myopathy, if it's not, the patient has some spondylotic changes on their spine, but they're totally atrophied in their hands, that doesn't quite fit. So you want to, I think the take home points for me to translate to you guys would be make sense of the patient. And if something doesn't fit with what you're seeing on the imaging, think about ALS and then think to look for the other features. So one of the biggest things is you have a patient who comes in with painless progressive weakness. Don't not look at their legs. Don't not walk them. Don't not look for fasciculations. You have to spend the time. And in this day and age in medicine, we don't get the time. You have to make the time, because that's to miss this diagnosis is devastating, because that's time lost to the family. And it's also important to make sure you're not missing anything treatable. So looking for all these markers. So that's kind of the message I would send to you, is make sure you are able to know the clinical features so you can then look for it on the exam. Any questions on, it was a kind of a big talk with a lot of topics. I could dive into SMA because that's an exciting one. But any questions? Do you have any? SMA?
So you're thinking that patient that you have, the drummer, will think it's totally ALS?
No, he has a compressive cervical.
Oh, he did?
Yeah, he's seen surgery. So this is a good example of, this is this, should we, I mean, do you want to save this for, since we could talk more about ALS if you guys are interested? Or,
Yeah, we can-
how long is this?
This is not that big.
Okay, you want to do it and then we can talk.
Okay. All right, so peripheral nerve hyperexcitability syndromes. Mainly as whatever I actually saw in the Continuum article was actually 6 main syndromes. 3 true hyperexcitability syndromes, Cramp Fasciculation syndrome, Isaac syndrome, and Morvan syndrome, and others which are mimics of hyperexcitability syndrome, including stiff person syndrome, rippling muscle disease, and a Schwartz-Jampel syndrome. Initially, when they started looking at diagnosing these conditions, they were giving all these confusing terms in neurophysiological phenomena that they actually found. They were, for example, saying that, oh, this might be armadillo syndrome, squander syndrome, syndrome of continuous muscle fiber activity, which is really all confusing terminology for these clinical spectrum of diseases. So Cramp Fasciculation syndrome. This is a benign condition, mostly involving fasciculations and myoclonus. In having these conditions basically in the distal motor axons, you'll find this really common that these syndromes actually have a voltage-gated potassium channel involvement antibodies, which kind of delineates that this is actually an autoimmune disease in not only the Cramp Fasciculation syndrome, but in all of them. With this Cramp Fasciculation syndrome, usually involving the calf muscles, but treatment is not really that a problem. They usually respond well with carbamazepine. Isaac syndrome is another condition, but this one mainly involves generalized myokymia. So myokymia is, myo of course is muscle, and chymia is a wave. In Isaac syndrome, it has actually 2 neurophysiological or I'll say phenomena, myokymia and neuromyotonia, but they're not the same. When they started looking at Isaac syndrome early, I mean, when they first identified myokymia, that was in like 1902. They first saw it in facial myokymia. Then they identified, oh, this is basically, can still see it in the general body. And then they identified the neuromyotonia. Again, with Isaac syndrome, it's actually a disease involving the voltage-gated potassium channels, which is a very common thing in all of these hyperexcitability syndromes, and has often involvement of a thymoma and a small cell lung cancer. Isaac syndrome has a like a mimic of the Duchenne muscular dystrophy in terms of the muscle hypertrophy of the calf muscles. However, of course, Duchenne doesn't have the myoclonus that you can still see over here. But the main clinical difference over here is that it will have dysautonomic features where you have patients having a lot of hyperhidrosis, sialorrhea, goosebumps, whatever, piloerection. It's all dysautonomic features. Of course, with the myoclonic discharges you can see on the EMG and the fasciculations.
So in Duchenne, of course, it's not actually muscle hypertrophy, it's calf hypertrophy. The enlargement is just fatty and fibrous tissue.
Yeah, but this is a true muscle hypertrophy. So what's the difference between your myotonic discharge and myokymia? So myokymia is actually a group discharge of a single motor unit action potential, which is at a less frequency than neuromyotonic, which is just bursts of a single motor unit action at a very high, much higher frequency, 150 to 250s. And that stops and continues. So it just bursts. You will see a burst of the discharge, then a stop, then a burst again. Morvan syndrome, let's see, it's very similar to Isaac syndrome. However, it has also the myotonic discharges, the dysautonomia, but with an addition of the encephalopathies. So you'll have these patients having hallucinations, agitation, delirium. But one of the key features of Morvan syndrome is that they often have insomnia and other sleep disturbances. Over here, this is a couple of tables over here. We're going to have a look at the each and every EMG discharge. So the myoclonic discharges, they come mostly from the motor axon, and they will have a. We're going to have a look on the pages now. You'll hear a marching band, and again, it's just a very short frequencies of 55 to 60 hertz. Unlike the neuromyotonic discharge, which is 150 to 50 hertz, and which is waxing and waning, they actually describe it as a pinging sound. Myotonic discharges, which comes from the muscle membrane, however, has also a wax and waning frequency. They call it like a reviving or dive bomber, and the complex repetitive discharges, which is basically a very stable complexes, and you'll see just the repetitive of this, the same discharge, just about very, very stable discharge, but it keeps on repeating itself. Over here, you can see. Sorry?
No, it's hard to describe these. Have you seen much of it?
Yeah, I'm going to go over
No,
them.
I'm saying it's hard.
Yeah, for me, especially if
It's
I
hard
didn't do
to
the
describe
EMG.
these.
Yeah, so over here, this is myoclonic discharges. And they say this is like, basically this is a raster form, which is just a dot matrix. That's what they call a master mode. And over here, this is the neuromyotonic, which is just a burst, it goes away. But over here, just infrequent, you see the less frequency. But over here, with a very high touch frequency. This is another video, the same video we saw before that. Yeah. Should be working. Was working early in the morning.
Basically, it sounds like a marching, like a. It's like a very right now. I'm trying to do what Dr. Zhang does.
Yeah.
But it's, if you notice, I mean, it's really hard for you guys if you haven't seen this. No one's going to expect you to know these discharges. But when we see this sound, it's very characteristic of a certain of a nerve irritability or hyperexcitability. And the classic board question is,
So,
where would you classically hear myoclonic discharges?
So the other one is basically radiation plexopathy.
Radiation plexopathy. Exactly. So
I was realizing it was working early in the morning. Also this room. Okay, so I'll just have to describe it. And this is the myotonic discharge. So
should I
it's,
try that one?
yeah, go ahead.
It's like, that's awesome.
Yeah.
I'll have to ask Dr. Zhang what he does.
The diving bob. They
So
call it.
it's like a crescendo, decrescendo, and you'll hear it from beginning to end, which is different from a CRD, a complex repetitive discharge, where it's like it'll just come and go without any warning. There's no change in the sound. And again, the importance of this is recognizing the discharge so you can make a clinical correlation with that. So CRDs are they're non-specific discharges, but they suggest nerve minor injury or irritability. You see them in diabetics. You see them in patients with chronic lumbosacral radiculopathy. Whereas myotonic discharge is very pathological and is most commonly seen in myotonic dystrophy, which is a whole other, autosomal dominant familial history with no treatment. So it is important to know these discharges if you're doing them and recognize them, but I don't know if you ever want to come out in the lab, hear them in actuality.
It's not working. I have them all there. No, it should. I don't know, it's- Okay. So over here, just a little table that shows the different signs and symptoms with each syndrome. So Isaac Mies differs from cramps in terms of they have the myoclonic discharges and myoclonic discharges, as well as the autonomic involvement, which is not in the cramp fasciculation. But in the Morvan, it's just about the same, except it's also having the encephalopathic agitation or delirium. And of course, they all have the voltage-gated potassium channels, antibodies, with mostly, you don't really see anything in the brain. Going to the hyperexcitability mimics is beginning with stiff person syndrome, which is basically a disease characterized by fluctuating muscle stiffness, which is really very painful, involving the limbs, the trunks, the neck. They often have, not really often, but in severe cases, you'll have lumbar hyperlordosis and gait stiffness, mostly associated with antibodies against the glutamic acid decarboxylase. So if you find these patients having type 1 diabetes, which is very common. EMG studies will basically show non-specific continuous motor activity, and usually the treatment involves IVIG. The other one, which I really found to be interesting, was a rippling muscle disease, which I kind of thought maybe they should have called it rolling muscle disease. It's because the muscle itself, when you percuss it, it will start rolling. I think I was not able to put the video here, but let me just put the link. It's really interesting. This should work. It's just for the stimulus.
YouTube is very presumptuous.
Yeah.
That's very fascinating.
Absolutely. Yeah.
So
So
what you do, I've seen one case. I think he was misdiagnosed as ALS actually.
other than Cramp Fasciculation.
yeah. So anyway, so with this disease, it has a gene NF3 involvement, which affects the membrane associated with skeletal proteins. Again, it's involved with myeloma and myasthenia gravis. And then the last one, which is Schwartz-Jampel syndrome, which is actually chronodystrophic myotonia disorder. Involves a triad of myotonia, facial dysmorphism, and skeletal deformities. The facial dysmorphism basically shows a small mouth, blepharophimosis, which is basically bilateral ptosis with a very small eyelid, and of course blepharospasm. These patients usually are very short stature, have skeletal abnormalities such as kyphosis and hip dysplasia, with a minor elevation of their muscle enzymes. Again, an EMG will show just myotonic discharges. And, the gene involved is called HSBG. Over here, you can see how they're really short statured, although the facial features are not really that prominent over here, but they should have a very small lip. And that's, of course, the but this is very not really short. Over here is basically just all the three hyperexcitability disorders, and just a summary of their involvement. Where Isaac is basically the hypertrophy of the calf muscle with the dysautonomia and hyperfibrosis, with the myoclonic and neuromyotonia discharges. With Morvan, again, it's just mainly about the same, except with the involvement of insomnia and the encephalopathy. Cramp Fasciculation syndrome, just the muscle cramps with basically no EMG findings, just except the fasciculations. The mimics, basically the rippling muscle disease, which is for just the rolling movement of the muscles when they're percussed. Stiff person, which is really the painful spasm and stiffness. And the last one, of course, the Schwartz-Jampel syndrome, which has the triad of the facial dysmorphism, myotonia, and the skeletal deformities. Right. So, in summary, the diagnosis of these hyperexcitability syndromes require a really high index of suspicion because they're not really that common diseases. But it's really important to identify them, especially that there is an autoimmune component where voltage-gated potassium channels, voltage-gated potassium channel antibodies are involved, which could underlie a neuroplastic disease such as myeloma or small cell lung cancer, which could eventually lead to treatment. Right. Any questions?
You want to tell him about our group?
But at the very end, he ended up not.
He ended up not.
I mean, it was a different.
We know. Okay, so 65-year-old gentleman.
Yeah, just 60.
Professional drummer, very popular in town. Plays at venues all over town in his band. He came in with like 5 to maybe
15 years. Actually.
15 years of weakness in his hands to the point where they kind of just started curling up, and it affected the way he played. He had to hold his drumsticks differently. Not really any neck pain when he came to us. He also has lost a little bit of weight, although he's always been on the thinner side. And when we examined him, I think he had brisk reflexes everywhere, occasional fasciculations in the arms. We saw that. Right?
Yeah,
in the arms, and no sensory deficits. Yeah. We took a picture or a video?
I have
Oh, that picture was
Oh
on.
yeah. So he had atrophy in the hands up to the forearm.
Yeah, he also had his lower extremity. I think the adductors were atrophy.
So
yeah, and he also had the temples really very atrophied, which we thought initially was like a general.
like cachexia.
Yeah.
Because he looked like so thin. No sensory symptoms.
No.
His gait was like maybe essentially
Yeah,
normal.
okay,
He was pretty
yeah.
independent, but he had visible atrophy in his hands. Did you guys all see that?
I think Holly, I think your picture is better.
Yeah, let me check.
Miles from
Just
the
wanna open that.
Any thoughts?
Let me check.
Send it to her.
Look here. This is a better picture.
So any thoughts? Anybody? Nobody? Nothing?
Is he having like any generalized weakness?
Not really. He was vague, but his biggest problem was he couldn't drum the way he's used to. It's both sides.
More so on the right side.
It's both hands. It's both hands,
Just
right?
a little bit more.
Perfect.
Okay, so we talked today about ALS, or is anyone thinking? It's unusual, right? So can ALS happen for that long? Yeah, in which scenario? Usually in the familial cases, which are mostly autosomal dominant, so there will be a family history. In his case, there's no family history. Anything else? What else could it be? You think it's ALS? No, right? Because 15 years is a red herring.
It's just bilateral upper extremities. So you think some sort of structural lesion in the neck.
So bilateral upper limbs, but his exam shows atrophy in the hands with some fasciculations, wrist reflexes in the lower limbs. Did he have upcoming toes? He had some clonus, maybe?
Yeah, close.
He had clonus. So what we were convinced he could have like a slower evolving form of ALS. It was painless. He had no sensory symptoms. He had atrophy and fasciculations, and he had hyperreflexia everywhere. Okay, that kind of definitely puts ALS up there. And he said he had no neck pain.
Any cognitive involvement?
Not really. No, pretty sharp. So we did his EMG, and it was
Yeah, it was
It
normal.
was completely normal. So, well, no, sorry.
No.
We needled the weak muscles in the hands, and they had spontaneous
The
activity.
fasciculations, everything.
But no. But when we put the needle in the weak muscles, he had spontaneous activity. But he didn't have spontaneous activity elsewhere. So in the upper proximal muscles, none in the leg, and none in the thoracic paraspinal. So why would I have checked all those areas?
Could they all be affected?
Yeah, so remember in his talk, he talked about the Ellis-Coriel criteria that you need to have signs of denervation in 3 out of 4 body regions. So if you're thinking of ALS, you have to check more than just the one body region, and we didn't find that. So he didn't meet electrodiagnostic criteria. So we have a guy with, again, atrophy and weakness in the arms, not much pain, hyperreflexia, and an EMG that shows denervation, but only in the weak muscles. Not meeting criteria for ALS, what would you do next? Where would you localize? Which part of the spine? Right. Right here. This is like what? So that's a good thought, but if he had a brachial plexopathy, he has bilateral. Why would he have a bilateral brachial plexopathy? Right, and then also that would not cause wrist reflexes in the leg. So where does this localize? Which part of the cord?
Anterior or anterior.
So the cord goes from the bottom of the brainstem all the way down to L1, L2. So where along the cord would you think to look, given the distribution of weakness? She mentioned cervical. Can we get any more specific than that? Yeah, so like the lower part of the cervical spine, maybe basically he's atrophied up until here. So maybe C7, C8, T1. And do we have a chance to just pull up his spine?
Is it unusual to have like to not have any sensory deficits at all?
Very.
For cord?
It's very unusual. So that's the part that doesn't fit with the cervical spine, is that he has no paresthesia, no numbness, because remember the dorsal root ganglia is entering at that same place where the motor fibers are leaving.
Because
So if you think it's at the spine, you would expect.
I, 'cause- 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 '
You guys have to
they
go?
are.
It's a one.
Yeah.
Let's look at it really
Oh,
quickly. Students will appreciate this. I hope. Bell?
Thomas. Thomas.
It's
Ball,
Bill.
ball, Thomas Ball.
Uh-oh. Oh, just do the T2 sagittal. No. Okay, so here's the cervical spine on sagittal view, T2 weighted. Is T2 or T1?
There's two.
Keep going. Look at that. There's like almost complete crushing. There's also, can you go down to the, is there anything lower down? Go,
Yeah, there
sorry,
was
go back
T.
to the midline. Definitely C3, C4, but also look at that. C6, C7. So he has kind of like a double crush on his cervical spine. And that is enough. I think they had a cord signal change too, right?
Yeah.
This is just very severe, like cervical.
This is a compressive cervical myelopathy. So the myelopathy is why he has brisk reflexes in the legs. Those anterior horns, the fibers traveling in the cortical spinal tract all the way down are causing brisk reflexes, but they're not weak because you don't have lower motor involvement there. You only have lower motor involvement where the nerves are exiting, which is at that level, C6, C7. Does that make sense? So he actually localized really well. We just got the cervical spine after.
He had a history of neck trauma. or
So
motor vehicle
he
accident or
then
something?
later said, oh yeah, I've had neck pain for years. I've